A very warm good afternoon to one and all present here. Respected Professor Jeevan Singh Kitiansar, Chief RP Center, Games New Delhi, all the faculty members, senior residents and my dear colleagues. We have gathered here for a special lecture by Dr Saurabh Jain, Consultant Ophthalmologist and Clinical Director at Royal Free Hospital, London. I would like to call Dr Rohit Saxena for welcoming our esteemed guest Dr Saurabh Jain. So please.
Thank you everybody for coming here, and thank you Dr. Saurabh for taking our time to visit the RP Center. On behalf of the Chief, faculty and all the residents of RP Center, I welcome you to this center, and we all look forward to your lecture. I would request Chief RP Center to welcome with a bouquet of flowers. Thank you very much, sir. Dr. Saurabh is a consultant at the Royal Free London Hospital, as well as he is the Associate Professor at the University College of London. And to talk more about him, tell him, of course, we will hear about him when he starts his presentation. He is a pediatric ophthalmology and strabismus and neuro-ophthalmology, and of course, neuro-ophthalmology associated. He does a lot of work in strabismus and children. He has a waiting list now, as he talked about. He's now, of course, started operating at the Moorfield Eye Hospital also. Currently, he will give us his experience about evaluating and managing patients with binocular or motility disorders, particularly paralytic strabismus.
Thank you very much, Rohit, and thank you to all the residents. It's so nice to see so many people here for a strabismus talk. So I don't know what it's. Just any joy? Is this mine?
Yes.
Let's go to new folder. No, this is not mine. I will take it. It's a Samsung USB. Yeah, just go to the updated Incomitant. Perfect. Thank you. Great. So hopefully this will all work and will load up. Let's see. So I left India almost 20 years ago, so it's so nice to come back and see so many young residents. Because one of the things I do there, apart from being a consultant ophthalmologist, I'm the training program director for ophthalmology. So I'm the training program director for ophthalmology for London, and I tend to, thank you so much guys, and I tend to be in charge of the simulation programs. It's been really good going around and looking at the simulation lab and seeing so many young residents, because for our residents, the pandemic has been a disaster, because it's a 7-year, in fact I got this here. So this is where I work. I work at the Royal Free, which is the hospital you see down there, and the hospital up there in UCLH. I do the ROP screening, so it's a level 1 unit, so we see a lot of children with ROP. So Roy showed me your ROP lab, which was great, and I teach at UCL as an associate prof. So this is what our structure is at the moment for ophthalmology. It's a 7-year training program, and what happens now, people enter straight after their internship. So the internship there is 2 years, so we call it Foundation, F1, F2, and after that we have one assessment for the whole country. So we only have 70 places in the whole of the United Kingdom. London only has 12. So we really get the best of the best. So then it is our duty when they come to us to give them a good training. And I think for this, the pandemic has been a disaster because we had to stop operating. We're all deployed to ICUs, etc. So they've lost a lot of time. And one of the things I'm trying to do is to see how we can use simulation to help. I have to say, there is no substitute to live surgery, but we do what we can to help with that. A question I get asked, and for me again, it's such a pleasure to be here in India. So first foreign visit I've done, I think in 2 years, and first pleasure time speaking apart from my kitchen table. So one of the questions I do get asked when I speak abroad is, okay, what can people come to the UK to train, or is it completely closed? And what's happened? The UK is very keen that they train as many of the local graduates for ophthalmology as possible, and because it's such a coveted specialty, we actually, we have a ratio of 5:1 for each ophthalmology place for interviews, not even for application. But there's always, opportunities. One of the things I'm really keen on is the dual sponsorship scheme. So we have lots of fellowships in the UK, and it's very, very possible if you want to get extra experience to go and do a fellowship. You just need to, if you just Google dual sponsorship scheme for the Royal College. So I think me and Rohit are negotiating to get submit, I think, there soon. But that is a possibility. If you ever wanted to come and do a fellowship, please write to me. All I need to do is to know one of your bosses there. That's all. And which I've met so many people. There is an opportunity. So do. I think it's nice to go abroad for a while. Just broadens your horizons. It just makes you think. You guys are doing amazing work here. I have to be honest. I don't think you learn completely new things or see things you've never seen. But maybe you learn a different way of assessing things or looking at things. And this is why it's so interesting. So we had Prof. Coker come and give a lecture at my center. It was a real pleasure to have him here. And he does more cataracts himself than whole of the country does, for example. So that kind of experience you can't match. So similarly, you learn different things in different places. So this, yeah, sure. Okay, so this is a very straightforward lecture. It's meant for my residents, and my residents have very little interest in strabismus the whole of the year. Apart from the 2 weeks before the exam, my clinic is full of people who want to learn everything about strabismus in those 2 weeks and just want to pass the exam. So this is a lecture really designed for them. It starts off really, really low, but hopefully it'll help you look at things the way we look at things in strabismus. So feel free to stop me at any time. It's a very informal lecture. I really want to hear from you. So this we're going to talk purely about incomitant strabismus. Okay. So strabismus is just a condition which your eyes don't work together. Comitant means wherever you look, you have the same deviation. Incomitant just means the deviation is different in different directions of gaze. Okay. This is what I mean. So base in, it's an exotropia. Go to the right, it's more, and to the left, it's less. Okay. Simple. That's an incomitant strabismus. The thing about incomitant strabismus is almost always acquired. Congenital squints very rarely cause incomitant strabismus. There are always exceptions to the rule, like Duane's is an incomitant strabismus from birth. Okay, same with Brown. But on the whole, if you see incomitant strabismus, it's almost always acquired. Same, you see diplopia, it's almost always acquired, and that's a red flag. Whether you do squint or not, especially with diplopia needs to be taken seriously. Especially with recent onset diplopia, very seriously. So that's the kind of thing causing incomitant strabismus. So I won't ask an RP resident group what the muscles do. This is more for my residents. But what I always say to them, you should know what muscle does what and where do you assess what. Why? Because very soon this will become very important. You'll see. Okay. So for example, look to the right. So the right LR and the left MR work in a synergistic way. With the same. Remember the herring and Sherrington is low. So you get a smooth movement to the right or dextral elevation. Okay. So when you look up, so your dextral elevation, the right SR and the left SO. So this is how muscles work. This is how we're able to maintain the same image on the fovea of both eyes. Okay. Now here we go. This is the patient. So I'm very lucky. I have a whole army of orthoptists who do most of the work, and I just get the glory. But I insist on a 9-gaze measurement for all strabismus patients. So they hate me a little bit for it, but I think over time they have learned to understand why that is. This is the patient. They have almost the same deviation everywhere. So this is a comitant squint. This one, not so much. Okay? If you look on in the texture version, the deviation is much more. So something's going on there. Okay? Let's go back to a diagram. So what does the texture version? The right LR and the left MR, which means there must be a problem with these muscles if you think it's a paediatric strabismus. Okay? So that's my rule number one of managing a patient with incomitant strabismus. If you want to do something, maybe try and work on the muscles that move in the eye where the problem is the most. And the patient will tell you don't need an orthoptist. You say to the patient, where do you see double here? Or just have an image, where does it go double here? Okay, and the side by side, one on top of the other, side by side. Okay, there's a horizontal problem getting more here. That's all you need to know. And we know what muscles work here already, so we're going to work on them. Okay, let me show you an example. This is a 15-year-old girl, came to me with vertical diplopia, as long as she can remember. She says, I cannot read. I'm going to university and I'm really worried. So let's just hope this works, okay? So she's looking to the left, you see, there's a vertical spin. So again, we use our knowledge, so she's looking in levo elevation, that's where the problem is. Now this is what puts people off squint. A report like this comes from the orthoptist and they're like, okay, let me go to the bottom line, what the diagnosis was. But let's just look at the report one by one. Okay, so look to the right hand side of the screen. You have three measurements in this 9 gauge. Top one is the horizontal, bottom one, the middle one is vertical, lowest one is the torsion. Okay, and what you're seeing here for this girl, she has a right over left, absolutely. The right over left is most when she looks here, 24 prism diopters, and when she looks here. So it's much more in levo version, most in levo depression. Okay, and look at the torsion. The torsion is much more in down gaze. So now you know that the squint is much more down there. Okay, and then you can look again here. This is just the ocular motility. So squint is always a game of two things: deviation and motility. Deviation and motility. So that's the deviation and that's the motility. Does it tire? Absolutely. The problem is most here. And if you look here, you have two muscles. This one is overacting, this one is underacting. So already everything is tying up. And that's the beauty of strabismus. It's very logical. Things on the whole tie up. And if they don't tie up, take a step back, look at it again. Okay? This is where the problem is. Now let's go back to our original diagram, okay? What muscles work in this position? Well, this one and this one, okay? And it's very simple. There's a right. So either you can make this one weaker or this one stronger. You can do either. On the whole, again for me, I like to stay away from the inferior rectus as much as possible. Also, this is the normal line. So probably best to make this one stronger. Okay? And that's what we did. Again, looking at now the motility, we again apply the same principles. You can either make this one weaker, so right IO, make this one stronger, right SO, or make this one weaker, the left IR. Now the deviation is much more here. We want to work on one of these two, and of these we're going to choose the superior oblique. So how can you add to this? You look at the additional investigation, just as for cornea, just as for retina. Then you use your clinical assessment and you use the investigation. Investigation shows you on a HES chart where is the biggest problem? Here. Huge superior oblique interaction. So for this girl, I thought I'm going to do superior oblique tuck. Okay, how can you confirm that on the table? So that just shows how the patient is lying. You're pulling the eye up, and then you can see what a loose tendon this is. So you can put the eye all the way and just bouncing on the tendon. So we do superior oblique tuck. There are many ways of doing it. Doesn't matter how you do it. You can use a bishop's tucker. I'll just use a squint hook. And I'm not going to show you a video necessarily, but this is what it should look like. So before the tuck, nice loose tendon. Okay. After the tuck, nice and tight. So you should just be able to just push the eye above a line. The joints are too tight. Now you have to warn the patient. I will give you a Brown syndrome. You say I'm going to give you double vision in upgate, but that's the price you will pay for being single everywhere else. And that discussion is golden. If you don't have that before, and the patient has it afterwards, you never warned me. I would never have accepted it. But you document it and you explain it and you explain it again. And the world we live in is not more litigious than it was when you were growing up, especially when I was growing up. So I think the discussion with the patients is really key in whatever surgery you do, because once it's knife to eye, it's too late. You have to discuss everything before. Okay. And this is what she looked like afterwards. She had a good result, single muscle surgery, but it's what went into the thinking behind it. Okay. But this is just this. Let me show you. So what else could the if you ask strabismologists, usually our go-to procedure for dealing with superior-oblique, infra-oblique myectomy. But my point of showing you this case was to say it's not always the right operation. It's the right operation for the right patient. You can do infra-oblique myectomy in a number of ways. This is how I used to do it. This is the eye held in upgaze and adduction. You find the infra-oblique. You hook the infra-oblique. You can see what you want to see is that white triangle. Unless you have white triangle, don't hook it. And that's why I say to the patient, don't make it bleed, because then you're looking for a pink triangle and a pink muscle. Okay, so I'm easily said, don't make it bleed. Find it, hook the muscle, and then you take an inch out of it. Now I have to say, I've almost stopped doing this because I find myectomy is in my hand, but not as effective as antrization. So I moved almost completely now to antrization. So I take an infra-oblique and I put it right next to the inferior rectus. Okay? What you should never do is pull it ahead of the inferior rectus. Then you can get something called an anti-elevation syndrome, because you stretch the neurovascular bundle and this big IO then just becomes an anti-elevator, and the patient will lose elevation and they will not like you. So never go ahead of the traditional teaching was Sparks point, 4 millimeter here, 2 millimeter here, and that's a recession. So you can do recession, you can do myectomy, you can do antrization. They all work well, but we just found, we did a study with Persian J posters this year, and we looked at all our patients. We found for us the antrization worked much better, both short term as well as long term. Okay, so second rule, be aware of the secondary effects of this surgery. Not all surgery do the same thing. What do I mean by that? So this is how I do a recession. So the way it is, when I operate at my NHS center, I'll never do a squint by myself. So all the residents do it, unless it's a multiple redo. And for residents, when you're doing squint, our residents don't suture anymore. They really don't suture. They only suture a phaco when it's gone bad, which means they are so anxious, so that's not a good time to learn. And so this they find tricky. So I do most of as hand back. Also, that means I can adjust them afterwards. So all my adjusts are also adjustable. Now, when you recess a muscle, recessing just means you're putting the muscle back from where it was. You get an effect in the primary gaze, of course, but then you get an additional effect in the gaze when that muscle is being used. What I mean by that, say you recess the medial rectus, okay? Eyes in, the medial rectus, your eyes will become straight. But when you use that muscle, when you look to this side, you get an additional weakening effect. And you have to be aware of that. Okay? And you can really use that. Similarly, when you resect a muscle, when you make it shorter, okay, the muscle becomes really tight, and it's a leash effect. So when you look away from the muscle, you get the most effect on it. And again, this is something you can use to your advantage. Okay? Yes, let me show you this. A 63-year-old Caucasian lady, a wife of my consultant colleague in the hospital, so no pressure, very high myo, double vision all the time in the distance, finding it very difficult to drive, otherwise perfect. Okay? This is what she looks like. By the way, this app is amazing. It's called 9Gaze. I don't know if you guys use it, but I now make residents take pictures of everybody pre-op. You see, there's not a lot to see. She was very worried about this actually. It was the main concern. But also, not a lot to see. But what she did have here was she had a small myopic esotropia. So we see a huge amount of myopic ET. I don't know if it's the same here, but it was much more in right gaze compared to left gaze. It was quite incomitant, which is quite interesting because you wouldn't expect really. You can expect a bit of near-distant disparity. You don't see this side to side, but she had it, okay? And first thing when this happened, you have to think of, is this a 6-month palsy? Is there any limitation on motility? But she didn't have any limitations, so we knew it wasn't that. Let's go back then to our diagram, okay? So for this, I could do, I can do two things, okay? I can do an MR weakening on the left side, or I can do a LR strengthening on the right side. Okay? Those are my two options. But let's just think back to what we just talked about. When you weaken a muscle, you get the most effect when you look away from that muscle. Which means if I weaken maybe the left MR and not give an effect in primary gaze, which uses the left MR to look to the right, you get an additional effect. So with this thinking, I just did a single recession on the left eye, which has an effect in primary gaze, but an increased effect in right gaze, wherever deviation is removed. So small little fact can really help you plan the operation. And the patient might say, well, it's my right eye that's going in. You say, yeah, fine, I can do the right eye, but if you just hear me out, this is what I suggest. and she was happy to. Sometimes you're not always successful. And some people will say, no, I'm sorry, just do my eye with the problem. I don't want you to mess around with a good eye. But she did, and she had a good outcome. Okay, rule number 3. There's no function in the muscle. There's no point in resecting that muscle. Okay, if you have a dead muscle, if you shorten it, it's a matter of time, it will elongate again. So no point in messing around with that. Okay? A 77-year-old Caucasian man came to me with an esotropia. Again, this is the example I showed you at the beginning. So he has an esotropia in right gaze. Now, unlike that other lady, he's got limitation of motility. There's a right sixth-nerve palsy. Okay? This is what it looks like. Just about to go for surgery, and you can see limitation right gaze, almost no abduction. I would say -4, -5 limitation of abduction. Here, there is no point in resecting the LR. You will not get much out of it. You need to borrow a muscle that will do the work of the LR. Okay? So, this is my nomogram for sixth-nerve palsy. What we want to know is there LR function present or absent? Because sometimes it's very difficult. If somebody's had sixth-nerve for a while, the MR is in contract, it's holding the eye in. We don't know whether it's actually, there's no function or it's just tight MR, but you can find out. Do a fourth generation test, just a cotton swab on the eye with some proximity canalotry, binoxinate, ask them to look to the side, compare the two, and you can see how much of a tug you get. Even with a tight MR, you will feel a tug. If you're not sure, I put some toxin in the MR to relax it, and that'll easily answer. Of course, once you put toxin, you cannot operate for 3 months, so just be aware of that. Or if you're going through, then you just answer the patient. If there is good LR function, fine, go recess resect. But if there is no LR function or very minimal, you have to transpose. Okay? So what can you transpose? This is what is in the books. I have stopped doing any of these because I find, firstly, you are dividing all the muscles, there's a high chance of anti-segment ischemia. Secondly, you end up with a knot of muscle there. If you ever have to go in, it's a disaster. Okay? And this is another paper from talking about anti-segment ischemia. So this was the paper from, he never published this actually, but he talked about just transferring, just superior rectus to the lateral rectus for these patients. That's it, okay? Just like this. So you recess the MR and you just pull the SR down to the LR and you add a posterior fixation solution here. And he found this give you quite a lot of, you can get up to 15 to 45 degrees more of abduction. So that became very much for me my go-to surgery for all the sixth-nerve palsy with no LR function. And it does tend to work well. The question is, why the SR? You're pulling the SR down, what if you pull the lid down? Why not the IR? You can use the IR. The problem with IR is you get a torsional effect, okay? So you can use IR, but really it will pull the eye down. So they also have a hypertropia with the IR, or they have intorsion with the IR, it will pull the eye back where it was. Otherwise, I don't do the IR. This was the patient I put in a crouch. This is me. You can see actually only the tiny exophoria. He was very happy. And he got huge improvement in abduction, which you will see now. So it does really work. Okay. And now I have changed to this Nishida procedure, which I feel is. So I spoke to Prof. Pradeep Sharma at a conference it was I think an APOS conference. He was telling me he was just doing it then. This is what I do now. So instead of actually dividing a muscle, I just put a suture through the muscle and attach to the sclera. So all you're doing is just pulling the muscles to the side. It works really well. You're not transecting anything, you're preserving the blood supply. And just even without the MR recession, we're at about 30. With the MR, we're at 50 diopter. It really works very well in my hands. Okay. So this is another example. Now, third nerves are a problem. You're only left with 2 working muscles. And again, in these questions, the pre-op counseling is absolutely key. You have to explain. What I say to them, we live our whole world in 9 blocks. 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm going to try and block this and block this. So straight ahead and down gaze, fine. And if I can do that, we have won. Okay? If you get anything else, that's a bonus. And you repeat this message many times because people forget, and often they come to me and say, well, it's no good, I didn't have a problem before, and you were very symptomatic before. So it's really important to to highlight this. Third nerves are a problem. Previously, we have tried various things. We will fix the eye to the anterolateral crest. We used to fit the LR to the periosteum. It was nothing really worked. But I really like this technique. This was Nishida and now Belinda Dargi. And what you do really, I'll show you actually. You take the LR, cut into 2, thread it all the way to the MR, and attach it to the MR. So basically, LR goes to the I'll show you. Okay. I will show. This is one I did. Thanks. So this is the eye. So that's lateral. This is medial. So what you do is you get the LR, you put it on a suture, detach it. Okay. I will. So it is detached. Okay. And you divide the LR into two. You get good assistance. So that's divided into two little strips. Okay. 2 strips of LR. And now you will thread them through this. So first you go inferior, so under the inferior oblique, then under the inferior rectus. Okay, for here, I'll just use a gas needle. I borrowed it from one of my plastics colleagues. And this is your inferior strip going underneath the IR. Okay, and then you attach it next to the MR. Okay. Similarly, for the top, you can see just being held there. Only for the top, you can do exactly the same. We have to be sure we're under the SO and under the SR. Okay? Because we will fill in the target, which is currently doing a talk for us tomorrow in the British meeting, and she said just takes the obliques off now. And I think that's probably a good idea, because what can happen is they're really tight, you can compress the vortex vein and postcoronal effusion, so you don't really want that. Okay? So this patient, this is what I did. Okay? Now, it doesn't look great. I know with her eye was all the way out. I want to just show you what happens. Just look at her adduction. So this is her LR. Now she has complete her palsy. Okay. So just look.
Just cover the right eye for me.
So I'm just going to ask her to look to her right in a second. Yeah. So it does, but she has a she has this disinnervation effect from before, but it does give you a lot of adduction back. And this has sort of become my go-to technique now. Okay. And this is my last rule, you'll be happy to know. If there is, so far we talked purely about phonetic strabismus. If you think it's restrictive, you have to release the restriction. End of. Okay. There is no way in doing a lot of fancy surgery. So how do you look at restrictive strabismus? Well, there are many ways. The way I look at it is a dog tied to a tree. Okay, they run and then they stop. They run, but they can only similarly. If it's a restrictive strabismus, they will carry out a saccade. It will be a normal saccade. They'll just come to a stop. Whereas if it's a paediatric squint, they have a hypermetric saccade. Also, remember Duction versus version. We love asking that in the exam. If your Duction is uniocular eye movement, okay, version is binocular eye movement. In a restrictive squint, they are exactly the same. Because the eye can't move anymore. In a paediatric squint, okay, say you have 6 nipples, they can't do it here. Close this out. You can always squeeze out a little bit more abduction. Why? Because you're getting more innovation to the muscle. And all this, of course, there's a second deviation or the primary deviation. I won't go into that. Okay, but this is how I think of it. If the thing is restrictive, you can release the restriction. Let me show you an example. This is a guy who came to us, had a retinopexy. So the way our training is ST1 to ST7. For ST7, we will keep on giving blocks, so he gave him a block. I think he probably gave him a block in the inferior rectus. So you can see he's got a bit of a hypertrophy in the left eye. So be aware, anytime you put local anesthetic in the muscle, it's very myotoxic because the destruction of the myofibrils, they regenerate, but it makes a very thick, very stiff muscle. So try not to inject. You can do it therapeutically. People have been doing that as a possibility, an anti-toxin, but this patient could not look up. Yeah. Now, the problem where I work in London is a very affluent area, so people are very, very conscious of this. And I did try to say to him, when do you look up like this? You don't need to look up like this. You can just, he really wanted something done. Okay, so here's what we look like, okay? Not very much in primary case, but up case, he had this left hypertrophy, okay? Do a force duction test. If you're suspecting a restrictive, there are a few things you can do. You can do an IOP in clinic, ask them to look up, check the IOP again. In fact, all thyroid patients will do that anyway to see if the IR is tight. If it's more than 6, you sort of know. But here we go. Okay. So this is this. So I'm pulling the eye up, and we will pull the eye down, and you can see you can go down very easily, no problem. When you try and pull up, you can really feel the tug. If you're not sure, do the other eye. You can really feel this tug. Okay. So that means it's a tight IR, so you need to release the IR. Okay? You're going to release the IR. This is a simple thing. Always, always, always divide this ligament into rockwood. If you don't, you will drag the lid down and the patient will never forgive you. You'll have a beautiful deviation, but they're looking at the lid and have to go back in. So there are many ways of doing it. You don't have to do a sharp recession if you don't want to. You can use it with a cotton bud or a German swab or triangular swab and push it back. You have to take the ligament block off the inferior rectus. Similarly, if you're doing the SR recession, you have to take the LPS off, or you will get a upper lid retraction. So this is very important. Okay? You have to take the ligament block put off, and he did it really well. Sorry, there is one more rule. Apologies. Say now this is end stage. Okay, if there's a limitation, but like a thyroid patient, you can't release it. When you've done a big IR recession, it's still limited. Match it in the other eye. Okay? This is a patient. He's had orbital decompression. He's had IR recessions. He's still got a right over left. You can't do anything more to the left eye. You can't do anything more to the right eye. But maybe you could do something to the left eye. So we do something called a retroepidural myopexy, which is called a Cardinal operation. Just put one stitch behind the equator. Nothing to do in primary case, but when they use the eye, you get a weakening effect. Okay? Or you can do a spot stitch, which is like a Hardy, which is adjustable. So you do recession and resection on the same muscle. Right, so that's it. That's me done. Okay, but just to repeat, just a few key messages. Incomitant strabismus is a surgical challenge. Please take it as such. Counsel your patients appropriately. Not every operation is suitable for every patient. Try and target the eyes, that muscle that move the eye in the direction where the problem is the most. If there's a limitation, try and release it if at all possible. If you can't release it, match it in the contralateral eye. And also, if a muscle is not working, borrow one that does work. Thank you very much for attention. Any questions?
Splitting a muscle and goes through the door. So what we did was we split the muscle who are the same origin, and we just change the insertion. It goes around the globe and attaches at similar points, just to parallel points. So I'm asking, what is the amount of torsion you're giving?
That's a very good question. And the thing we squintologists, let's see if I can pull that up. The squintologists tend to forget actually that there is no, when you do a recession or resection, muscles are not these muscles you see. There's a whole pulley system, the whole T-non's capsule is attached. Just because you change an insertion doesn't actually mean you are doing, that's all that's going to make a difference. So we worry hugely. Any bifoveal patient, you put a muscle in a different place, you always worry about torsion. In this patient, I have to say, because we tighten muscle in a spiral of Tilo, I haven't seen any torsion. I haven't done a lot, but I was speaking to my colleagues who have. There's something we have not seen so far. Also, we work with really good orthoptics. Even if they have a tiny bit of torsion, we can give them the prism in the glass, and it's usually not a problem. But I have to say, in this group, they already are so miserable because they've got their eye down and out, and they've got huge amounts of torsion already. They don't seem to be an issue.
Thank you so much, sir, for such a brilliant and wonderful lecture. I'm sure all the students who have attended here will be benefited greatly. I would like to call Professor Rohit sir to say a few words.
Thank you, Dr. Saurabh. That was extremely enlightening and very, very nice, of course. Like is the problem in UK. I think all residents share the same problem of managing to understand strabismus can be quite a challenge. But I'm sure a lot of them would have gained an adequate understanding, and I hope they can go back and look these things up. These are all among the newer things that are being described: lateral rectus to the medial side, the superior rectus transpositions, the inferior nasal transpositions. You described the anteriorization. So all of these surgeries you've been seeing here being done. Nishida's, he of course, as he mentioned, Professor Pradeep Sharma was very, very fond of the Nishidas. He's the one who probably made it more popular than Nishida himself. So that's so. As I said, you've been seeing these cases. It's a totally different perspective, but it's very nice to see that even in the UK they do the same thing that we do here. So Thank you, Dr. Saurabh, and Professor Coker also would want to, talk a few words about you and his memories of interacting with you earlier. Professor Coker, please.
Okay, Saurabh. So, Saurabh I met through Dr. Jeffrey Woodruff. If you guys remember, Woodruff had come here about 20 years back. Rohit was there. So, we had a senior resident called Nachiketa Acharya, right? So, he was like one of the people and then he went to UK. His wife was Vinita Muchi, who was working under Woodruff. So, I get a frantic call from Nachiketa that boss, their boss arrives. I said, what do you want? He said, he wants to take a lecture here. I said, fair enough, because Dr. Ghosh was there. So you must have told you about Dr. Ghosh, Saurabh. Dr. Jeff must have told you about Dr. Ghosh.
No, I told you, but that time I moved on.
Okay. So what happened then? He comes here. He was a British, original genuine British, not like Indian. He's not Indian. So he had the bow tie and all those. He comes here and Dr. Ghosh caught him outside. Then the time was at 3 o'clock, so 3:30 he says, and he was a senior fellow and he was a true British. He said, my time is there. Can I go inside? So Dr. Ghosh said, Fala, go inside and follow you. I think most of the guys won't know Dr. Ghosh also here. So when he came, he started his talk and the talk finished and all. So he said, we do about 150 cases in about 10 years or something. And so all the result turned towards me that much. I think we finished in 2 months. So next day I called him to come to the OT. So Dr. Woodruff came to the OT at 8 o'clock and we finished by 1 o'clock, about 9 patients, and he saw. So when we started, he was telling that we use these machines and that, and this is the parameter. By the end of the OR, he said, you mind if I take the parameters of the machine, because it's a machine which works, but it's a person behind the machine which knows what he's doing. And that day now we have become very good friends. We're a genuine person. He started mentioning about Saurabh. He said 3-4 times, and you must be doing Saurabh. I said, well, I don't know much, because I didn't know you by that time, right? So I met you first time with him in UK only, I think, when we met, or you were here. Oh, when he came again, we came here, he came for lunch, then we met. So what I'm saying that RPC gives you so much, like Nachiketa, Vinita Muchi, I'm telling you, because it's all a full circle. So all of you tomorrow will be outside, and you have people there very quick. So wherever you touch, anywhere, in any sphere, anywhere in the world, I think you'll find a RPC guy who's doing brilliant. I'm not saying the MMC guy is not doing good, but MMC guys are perfect, very, very good. Yes, but see, even he wanted to come to RPC for a lecture. No, Saurabh is a little, not a usual MMC guy. We have seen lots of MMC. He's little aberrant, he's an incompetent MMC chap. He's not a competent. So, what I message for the resident is that please do whatever you're doing. You got the best of the facilities here. Every equipment you have here. Europe, even the UK, there are so many machines to work on. The FECO machines, the type of surgery they do and what we do, it's world apart. You guys are much, much advanced. I mean, Saurabh will agree with me on that. Number game is more, and of course, their management. Now, what I learned from Woodruff was all the 200 patients he's following for 3-4 years, they all had contact lenses and they were followed up meticulously. And I here in the last 20 years have not even put one contact lens for a pediatric cataract, which I think is a shame. But there are certain good things about you and certain good things about us. So I tell my resident again that Saurabh is always willing to. I mean, if you want to go there for residency, I think he'll go out of the way to help you out. So please use the opportunity, and thank you very much, Saurabh, for being here.
I also wanted to thank Saurabh. If you all remember, Savnik Sen was our resident here. He was my thesis candidate. He's doing his medical retina down south at Arvind. And he off the cuff just wrote Saurabh to request for UK sponsorship. I mean, I was to be his Indian sponsor, but he was looking for, and he just wrote to Saurabh, and Saurabh just immediately agreed. And hopefully within the next 6 months or so, Savnik will be going to UK to work in medical retina. So thank you very much for that, and I'm sure that will give a lot of hope to many of our residents here who will now take your emails when they want to go to the UK. So I think that brings us to the end of the evening. I would request our chief, Professor Tityal, to just give a blast and say a few words. So this is a blast just so that you can remember your visit here at RP Center.
It's been a real pleasure. Thank you very much.
Good afternoon to all of you, and such a nice afternoon to have you all in this lecture session after a very, very long time. This is, I think, one of the largest gathering we had for the last 1.5 years because of COVID. And it all because of Saurabh has come to RP Center. And the name as such, you know that Saurabh what means. And that gives you, incentive for to do a better work for future. And you are the future. And you people are going to take the institution, the country to a status which people are looking for Indians as such. And all Indians are doing great across the world. That's only because of upbringing and the teaching which you get in this particular country, which is not available in anywhere in the world. So you people are really privileged group of people of this country in this premier institute. I always say you are the best people from this group of people who are looking for a residency in Ophtha. You will be the best. So you have to prove that you are the best. So make sure you take this time with you, because time will never stop. It will keep going. So you have to run with the time. And it's very difficult to go with the time as such. But you can always catch up also. That opportunity always given in somebody's life. So if suppose you are not getting today something, that may be missed. And I'm pretty sure people can catch up that also. That's a thing which is a learning phase. And today we had such a nice talk on a Squint, because it's, I think, agent for me also listening to some Squint talk. But he made it very simple way of thinking, which I never thought that Squint would be like that. Always I had that 9 cases coming by. Very difficult thing, but the way he showed it was very simplicity in that explanation of whatever he showed us. How to think of a particular muscle, his action, counteraction, then looking for what options you will have. Very nicely explained. Thank you, Saurabh, for that. And I believe that agents are here to interact with you. That's a good time for them also to have somebody coming and talking to that gentleman who's come all the way from UK. That's such a difficult time. And we should take this opportunity and make sure it benefits all of us. Thank you again, and you are most welcome to go around the center, maybe tomorrow OR. And Dr. Ocular is very fond of showing his surgeries. He might be there. So by the end of his surgery, you might take his parameters also. Thank you again, and I wish you all the best.
Take him around. I need a bow tie, Saurabh.
Saurabh, we're looking at a bow tie for everything.
Thank you so much, sir. Thank you everyone for coming here.